Okay. All right. Well, thanks everyone for joining us today. This is part of our webinar series where we're covering standards and measures in the 2025 recognition criteria. So everything that we'll be talking about today for Standard 2E will actually be implemented in January of 2025. So it's not relevant currently, but it will be relevant starting in January of 2025. So again, we appreciate you coming today, and we'll have lots of opportunities to answer any questions you might have after my two colleagues present on this standard. So I'm going to just turn it over to them.
Great, thanks, Amy. Well, good afternoon, everyone. My name is Becky Velasco, and I'm a verification specialist with the Patient-Centered Primary Care Home Program.
And good afternoon, I'm Amber Anderson, an improvement specialist with the program.
Thank you all for joining us for our webinar on PCPCH Standard 2E. First, I want to go over just a few webinar logistics and Zoom etiquette reminders. This webinar is being recorded and will be uploaded to the PCPCH program website. If you're having any technical difficulties, please private message Amy Harris for help. If you feel comfortable, please have your camera on and put your name and organization info up. And any questions or comments you have can be put in the chat, and we will answer them during the question and answer session at the end. Here's the agenda for today's webinar. I'm going to start by providing a brief overview of the 2025 PCPCH recognition criteria. Next, we will deep dive into PCPCH Standard 2E. Next, we will share additional PCPCH resources and upcoming webinars. And last, we'll have some time to take your questions. The Patient-Centered Primary Care Home Program was established in 2009 by the Oregon Legislature as part of the state's broader health system transformation strategy to improve access to care, reduce costs for patients, and improve population health. The standards are developed in partnership with an advisory committee and have been revised 5 times since 2009. The 2025 PCPCH standards were developed to support OHA's strategic goal of eliminating health inequities by 2030. The standards specifically help primary care practices build their capacity and processes to address inequities in their patient population. All practices applying or reapplying for PCPCH recognition after January 1st, 2025 must meet these new standards. For more information, I would encourage you to watch the recording of the 2025 PCPCH Standards Overview webinar, which is on our website.
So today I'm going to review PCPCH Standard 2E. PCPCH Standard 2E is in core attribute 2, which from the patient's perspective means take responsibility for making sure we receive the best possible health care. The intent of Standard 2E is as follows. Ambulatory care sensitive conditions are acute or chronic health issues that lead to potentially preventable hospitalizations or complications when not treated in a primary care setting. PCPCHs play a critical role in bending the cost curve by ensuring that ambulatory care sensitive conditions are treated well to the patient's satisfaction and in most cost-effective settings. Timely, high-quality, actionable data can help practices identify patients experiencing unplanned or adverse utilization patterns, as well as patient subgroups experiencing disparities in those utilization patterns. They can target areas for improvement. It is important that practices monitor ambulatory care sensitive conditions, utilization measures, and disparities that are meaningful for their patient population as a whole. Ambulatory care sensitive condition utilization measures are metrics that reflect to the extent of which patients are experiencing potentially preventable hospitalizations, condition advancement, or emergency services. These metrics typically center on hospitalizations, readmissions, condition complications, emergency department utilization, follow-up after those events, resource stewardship or utilization of relevant preventative health services, either for specific conditions, groups of conditions, or for all causes. Please note that while there are sometimes exist some overlap between ACSC utilization measures for 2E and the primary care quality measures referenced in PCPCH Standard 2A, practices attesting to both these standards must select different measures for 2A and 2E. Standard 2E is a check all that apply standard. That means you may attest to all of the measures that describe your practice's activities. There are two measures in Standard 2E. The first measure is 2E2. PCPCH identifies patients experiencing unplanned or adverse patterns in at least one utilization measure and contacts patients, families, or caregivers for follow-up care. This measure is worth 10 points. The second measure is 2E3. PCPCH identifies patients experiencing disparities in unplanned or adverse patterns and at least one utilization measure and contacts patients, families, or caregivers for follow-up care. This measure is worth 15 points.
Let's go ahead and take a closer look at measure 2E2. A practice is meeting measure 2E2 if it is doing all of the following. First, it tracks at least one ambulatory care sensitive conditions utilization measure among its patient population from one of the qualifying ambulatory care sensitive conditions utilization measures lists. The qualifying ambulatory care sensitive conditions utilization measures lists are lists of primary care quality measures provided by select measure stewards that PCPCHs may choose from to meet Standard 2E. Links to all of the qualifying measures lists are listed in the TA guide. The range of ambulatory care sensitive conditions utilization measures practices can choose from is significantly expanded under the 2025 standards. Available measures lists include CCO performance metrics, the CMS Children's and Adult Healthcare Quality Measures, and several more. Please note that the utilization measure selected must be relevant to the practice's patient population, and the data used for tracking must be aggregated across all relevant providers and patients in the practice. For example, if a practice selects a utilization measure from the CCO performance metrics list, they must track data for all applicable patients at the practice, not just Oregon Health Plan members. Second, the practice analyzes the utilization data to identify patients with unplanned or adverse utilization patterns to inform appropriate interventions. Last, the practice has a policy and procedure for contacting these patients to evaluate their status and make a follow-up appointment or facilitate other appropriate interventions if needed. The practice's policy must define the appropriate contact period and include a process for documenting that systematic follow-up was completed. When contacting patients, the practice should offer care to prevent worsening of a condition, clarify discharge instructions, and encourage follow-up care. Follow-up care may include, but is not limited to, additional care coordination, physician counseling, telehealth visits, engagement with clinic team members with expertise in care management and/or self-management support, such as traditional health workers, nurses, or behavioral health providers, or referrals to community resources, such as disease or case management and self-management support programs. Practices are encouraged to partner with community partners where helpful and appropriate. Overall, the main change in this measure from the 2020 standards is that practices will have a more flexible menu of utilization metrics to choose from, which will be easier to align with utilization measures being tracked in conjunction with their CCOs and other partners. Here's an example of activities that demonstrate successful implementation of Measure 2E2. A practice tracks its performance on follow-up after ED visit for alcohol or other drug abuse or dependence, and develops procedures to contact patients that have a higher frequency of emergency department visits to ensure that they are scheduled for and receive appropriate interventions in a timely manner. The practice contacts patients, families, and/or caregivers via phone, patient portal, or letters. These interventions are documented. As you're completing your PCPCH application, we strongly recommend you gather and save all documentation that would be needed for a site visit. At a site visit, you will be required to show this documentation to the PCPCH program to demonstrate you're meeting the measures. For Measure 2E2, you would need to provide, first, documentation demonstrating that the practice is routinely tracking one or more ambulatory care sensitive condition utilization measures from one of the qualifying lists. 2, a policy, procedure, or workflow for tailoring interventions for patients with unplanned or adverse patterns in the utilization measure being tracked. And 3, examples from the medical record showing that the practice contacts these patients, families, and/or caregivers to evaluate their status and to make a follow-up appointment or facilitate other appropriate interventions.
Under the 2020 standards, Measure 2E3 is focused on meeting benchmarks or demonstrating improvement on utilization measures. But under the 2025 model, it will instead be focused on identifying a disparity in your utilization measure and following up with those patients. This revision was made to align with OHA's commitment to supporting a primary care delivery system that meets the needs of those experiencing health inequities and barriers to utilizing primary care services. Now let's review the specifications for the second and final measure in this standard, Measure 2E3. The PCPCH tracks at least one ambulatory care sensitive condition utilization measure among its patients' population from one of the qualifying ASCS utilization measure lists that was mentioned on page 57 of the TA guide. The utilization measure selected must be relevant to the practice's patient population, and the data used for tracking must be aggregated across all relevant providers and patients in the practice. For example, if a practice selects a utilization measure from a CCO metrics list, they must track data for all patients at the practice, not just the OHP patients. If a practice is attesting to both 2E2 and 2E3, they may choose either the same utilization measure they're tracking, or they can track two different measures. Second, it analyzes the utilization data to identify one or more patient subgroups that are experiencing disparities in the practice's performance on its selected measure. Health disparities can be defined as differences in the presence of disease, health outcome, or access to healthcare services between various populations that are not due to differences in healthcare needs or patient preference. In the context of this measure, Health disparities refer to a difference in a PCPCH's performance on a utilization measure between one or more patient subgroup and its general patient population. Patient subgroups may be defined as characteristics such as race, ethnicity, language, disability status, gender, gender identity, sexual orientation, age, special or complex health need, social class, geographic region, life circumstance, health-related social needs, or other characteristics relevant to the patient's population. Third, it has a policy and procedure for contacting those patients to evaluate their status and make follow-up appointments or facilitate other appropriate interventions as needed. If the practice's policy must define the appropriate contact period and include a process for documenting that systematic follow-up was completed. C2E2 for examples of various types of interventions. When contacting patients and facilitating interventions, the practice should consider this patient's subgroup's unique barriers and needs. Please note that practices attesting to both 2E2 and 2E3 must be able to demonstrate that its overall follow-up or intervention strategy for all patients within an adverse utilization pattern considers the unique barriers or needs to that patient subgroup experiencing those disparities. So here are a couple of examples of activities that demonstrate successful implementation of Measure 2E3. A practice is tracking its performance on ambulatory care emergency department visits. It is able to segment utilization data by language and discovers that patients whose primary language is Spanish are visiting the emergency department at a higher rate than other patients. The practice already has a follow-up workflow for all patients who demonstrate high risk or high utilization of the emergency department, but in lieu of this disparity, the practice works to ensure that the workflow includes Spanish interpretation and translation services. Next example is a practice is tracking its performance on prenatal and postpartum care and breast cancer screenings. It is able to segment its data based on patient's address. The practice finds that rural patients are experiencing a disparity in these measures and decides to incorporate various resources into its existing patient follow-up and calls and interventions, including transportation options under OHP or local agencies and information about mammogram mobile van locations. At a PCPCH site visit, you would need to provide the following pieces of documentation to demonstrate that you are meeting Measure 2E3. Documentation demonstrating that the practice is routinely tracking one or more ambulatory care sensitive condition utilization measure from one of the qualifying lists, and how it has identified a patient subgroup experiencing a disparity in the practice's performance. Second is a policy, procedure, or workflow for tailoring interventions for patients in this subgroup with unplanned or adverse patterns in the utilization measure being tracked. And lastly, examples from medical records showing that the practice contacts these patients, families, and/or caregivers to evaluate their status and make a follow-up appointment or facilitate other appropriate interventions.
So that ends our presentation on Standard 2E. The PCPCH program is hosting this webinar series to assist practices and other community partners in understanding the 2025 standards. Webinars are scheduled every other Friday through December. You can find a complete list of topics and registration information on our website. The next 3 webinars are listed on the slide. I hope you'll join us, but webinars will be recorded and posted on our website if you can't make it. This final slide is additional resources that you may find helpful. The first is our PCPCH program website. The second is the 2025 TA Guide with detailed information about how to implement every measure and the documentation requirements. Next is a link to our TA resources webpage. And finally, the community engagement report and evaluation. You're always welcome to reach out to the PCPCH program with any questions through our program email.
Great. Thank you, Becky and Amber, so much for presenting that. So now we're going to move on to any questions that folks might have. I'm going to ask Rachel to stop sharing the slides, and we'll move on. So let me just check the chat here. If anyone has a question, you can pop it in the chat. You can also raise your hand and unmute yourself and we can call on you. So it looks like the first comment is from Gary from Asante. Gary says, thank you for the examples. It helps to put the standard into context. Good. Thank you for that feedback, Gary. We really feel like that's an important piece of practice is understanding the measures. And so we give as many examples as we can in the TA guide. There's lots more too. We just pulled these out for this particular presentation, but we always try to give examples in the TA guide for all of the standards. So thank you for noting that. Let's see, Deborah asks, can patients on OHP insurance be considered a subgroup for disparity findings? So that's a good question. And the answer is no, not for this particular measure. We really would be looking at you to look at subgroups that are related to some sort of demographic or health-related social need characteristic that would be more defined than just being on Medicaid or being an OHP member, which is a really broad category. So it would have to be a bit more defined than just that. So you could certainly use that as one of your criteria if you want to look at your patient population. If you want to use two criteria, which is something we didn't actually talk about in this webinar, but you could do that as well if there's more than one characteristic in which you would like to segment a subpopulation. You could do that if you want to pick OHA or OHP members who speak Spanish or OHP members whose primary language is something other than English. You could certainly do that, but just as a category of itself, it wouldn't be eligible for this measure. That's a good question though. Okay, so let's see. Which utilization member is, or which utilization measure is the ambulatory care emergency department visit list under? I thought that this option was removed from the TA guide. So I'm actually going to defer. Rachel on our team has been the one that's been really keeping a close eye on all of those lists, the measures lists that we have. So I don't know, Rachel, I'm going to put you on the spot and ask, do you happen to know that off the top of your head, which measures list that is a part of? If not, we can certainly look it up and let you know.
I want to say, I could be wrong, but I want to say it's under the HEDIS measures currently. Is that all cause emergency department visit tracking? But I can check actually right now to hopefully get an answer by the end of this meeting.
Okay, great. Thanks, Rachel. And I'll just say, if anyone else knows, feel free to unmute yourself and chime in. And maybe that's one that somebody knows a lot about. So that's a good question. Any other things that folks want to know about or any other questions? The other thing too is, I don't know if anyone is already doing this type of work in your practice. I know that some practices have already been implementing these types of standards, even without the guidance from the PCPCH program. So I'd be really curious to hear from anybody that might be doing this work already. Maybe you're already looking at subpopulations within your practice and developing some targeted interventions. So I'd be interested to hear from you as well if anyone's already doing this work. Oh, someone said, I would love to hear Christy says, I would love to hear examples of what other pediatric practices are using to meet this standard. So like what other metrics? I don't know if I don't know if our site visit team has seen, I know it's a new measure, so we haven't done any really site visits on this in particular, but I'm thinking about the way that the measure is currently written, if you've seen any pediatric practices that might be using some of those measures that we currently have, even though the list is pretty narrowly focused currently.
I've seen ED utilization track quite a bit with pediatric practices. You know, maybe you're not getting so many hospitalizations as like a family medicine or internal medicine practice, but certainly still see a lot of ED visits among that population.
Mhm. Mhm. For which then you could look at what sort of like a subcategory within that. Maybe it's your families who are speaking a language other than English, or your families who live in like we gave in another example, maybe they're your families who live in more rural areas compared to your other patients. So let's see here. Oh, and Deborah, thank you, Deborah, for chiming in. The best measure for pediatrics is all-cause utilization. Great, thank you, Deborah. Deborah she's the executive director of Children's Health Alliance. She has a lot of experience with that. Okay, let me scroll up and see.
And I guess, Christy, to answer your question, yes, in the 2020 standards, that ED utilization wasn't an option. But as Becky said in the presentation, one of the bigger parts of this measure is that we've broadened the lists that you can use to pick a utilization measure that's going to best serve your practice. So that is a change in the new standards, in the 2025 standards.
Mm-hmm. And the other difference as well is that if you remember, I'm sure you probably all do, the current standard requires that a practice meet a benchmark, and that particular measure did not have a benchmark that was associated with it, which is why it couldn't be used for the 2E3 measure. So, but now that we're not requiring benchmarks, it's just you and the practice utilizing this measure to do outreach and interventions for patients who experience these adverse utilization patterns. We can broaden it for sure. So,
I just
okay.
want to add as
Oh,
well. Oh,
yeah,
I was just
yeah.
going to add that, so I just checked and it looks like right now emergency department utilization is listed as a measure under both the HEDIS set as well as the CCO performance metrics. It's searchable right now, the 2019 specifications. That may change in the future. It's always important to check what metrics are current whenever you attest. And it's also important to keep in mind that it does need to apply to all your patients. So these specifications, it couldn't just be for Medicaid patients. You would have to consider all of them, but there are specifications currently available under both those lists.
Thanks, Rachel. I knew you could find that quick. So here's another question. Suppose you stratify by one of these demographics and find that there is no difference between that group and the general population. Would that still qualify? So the answer to that is no. We really are looking for you to use, at least within this measure, to look at any of your patients that have disparities in the utilization measures. As you can see, or as you'll read in the TA guide, the categories in which you can subdivide or stratify your patient population are very broad. It's everything from age to sex to gender to location to primary language. So we really are looking for you to identify a portion of your population or a subgroup within your patient population that is not doing as well on these utilization measures or on a utilization measure, and then addressing that. So we would not be able to verify that measure if you found that to be true. And we would probably encourage you to maybe select a different utilization measure in which you think, in which you believe there might be disparities. I think probably talking to your providers and talking to your quality team, you may be able to, think through what that measure could potentially be for your patient population before you run the data. So, but that's a good question. Hey, Deborah. Okay. Okay. A thank you to Rachel from Robin. Okay, I'm just looking through. I don't see. I think those are all the questions that we have in the chat. Is there anything else that folks want to know about? Any other questions? Oh. Okay, so Deborah says, volumes of ED and IP events are just small for pediatric relative to the other populations. That makes the subcategories very small and variable. That is true, Deborah. And I just want to note that we don't have any requirements around the size of the subpopulation. So, which I think is important to note. So in those, if you are running some kind of analysis and you find that your subpopulation is maybe even 10 patients and you're doing something special for those 10 patients, then that's great. That is what we want to see. And so there really is no minimum requirement around that. It's just that you're doing something to address a disparity in your patient population, which is really what we are trying to get to with this particular measure. So, but yes, you're exactly right. Some of those populations can be very small. And then Deborah's also asking, Rachel, if you could put a link to the HEDIS list in the chat, the one out of the TA guide. Great. Any other questions or comments? Okay. Well, as Becky said, we always welcome your questions, your comments, your feedback, your examples. If you're doing this kind of great work already, we would love to hear about that too. One of the things that we haven't really talked much about yet on these webinars is that we do plan to do some shared learning around these measures coming up perhaps at the end of this year, but definitely into 2025. So we really are looking for practices, so more like learning collaborative style, where we really have practices come in and present and talk about what they're doing to meet some of these standards, particularly the ones around health equity. And so if you're already doing this kind of work in your practice, or you know others who might be, or maybe you launch something that's amazing in the next couple months in preparation to attest to the new standards, please reach out to us, because we would love to hear about that and share it as well, so that you can share it with others. So again, please don't hesitate to reach out to us with questions or comments or concerns or success stories. We would love to hear all of that as well. So with that, I'll end the webinar and just thank everyone for attending today, and thank you to my colleagues in the PCPCH program for presenting and for answering questions that stump me sometimes. So thank you all very much. Have a great afternoon and a great weekend.